like you mean it. It takes a minute to believe it. Keep on watching those other girls. You can see what they take me for. I'm authentic and you feel it. Take it or you leave it. I have 1,000 watts pure power. You'll hear wherever you are. And my sound can never be broken. So girl, just give me a sign. 1,000 watts. That's what I got. 1,000 watts. I have a lot. 1,000 watts. That's what I've got. 1,000 watts. I got too much. Take a listen to your other side. Climb aboard and take a ride. I've been hoping you believe it. Reach on in to receive it. I'm not looking for the only one. We can just try and have some fun. Doors are closing and we're leaving. In the future will we be there? I have 1,000 watts pure power. Glowing hot like a lamp. And my sound can never be broken, darling. So girl, give me a sign. 1,000 watts. That's what I've got. 1,000 watts. I have a lot. 1,000 watts. That's what I've got. 1,000 watts. I've got too much. When the lights down shining bright, I got the sound and do it right. If we were making sweet music, I'd have the beat and never lose it. Keep on watching those other girls. You can see what they take me for. I'm original, feel it. I say my words and I mean it. I have 1,000 watts pure power.
Start. Good evening, everyone. My name is Erta Kalanji, and I'm Director of Partnerships at One Health Trust. On behalf of the organizations who came together today to organize the launch of the Lancet series on antimicrobial resistance, I'd like to welcome you all for joining us today. I invite Dr. Ramanan Lakshminarayan, President of One Health Trust, to open tonight's evening.
Thanks, Erta. Good evening to all of you, and it's so great to have all of you in one place. I feel like we've been doing Zoom and other things for a while, and we haven't actually met many of us. So, friends, the problem of antimicrobial resistance is often described as either not urgent or too difficult to solve, and neither is really true. So, if a problem actually can kill 15 million people over 3 years, the same number as COVID did over 3 years, it definitely can't be classified as not urgent. And if a problem can be substantially addressed with interventions that we know quite well, water, sanitation, hygiene, vaccination, infection prevention control, and access to existing drugs, then it surely is not a difficult problem to solve. So I don't think it fits in either of those categories. Each year, as we know, 7.7 million people die because of bacterial infections. Many of these can be prevented. Many of them can be treated with cheap antibiotics that we've had for a long time. But many will also need new antibiotics, but many of which won't reach the patients who really need them unless we plan for that to happen in a serious way. So we convened this Lancet series to bring the best global evidence to bear to address 4 questions. What's the status of AMR, disease burden, and effective antibiotic access? Who is affected? What global goals are at risk because of our failure to safeguard antibiotic effectiveness and to use them wisely? Second, what is the burden of AMR that is avertible with interventions that we already understand well? Third, what do we need the new drugs for? What can we do to make sure that any new drug that comes to the market, first of all, makes it, because that's still not clear. And then also when it does make it, it reaches patients regardless of where they live. And fourth, what do we need to get done this year at the UN General Assembly? And are these aspirations achievable, feasible, and how can we collectively catalyze action? I'd like to thank the 40+ authors from literally around the world who have worked incredibly hard to bring this series from an idea just less than a year ago. We met on June 2nd in Addis Ababa last year, and we have the series today, to now what is a finished product in your hands. The editors in the Lancet have been tremendous in their support and just the sheer work in bringing this to completion. Obviously, the entire team, but Anna Matus has really been our editor for this, and she's done an incredible job, but the entire team has just done an amazing job in helping us get to the finish line, and I can't tell you the amount of support we've had to do that. To our courses hosts today, they're all listed out there, but I'll mention Africa CDC, which also hosted our first meeting in Addis Ababa. It was very important to us to get this process started in Africa, in Addis, to ensure that this is a process that was owned from the places where people were actually at risk. US CDC, the AMR Action Fund, the Global AMR R&D Hub, FIND, IFPMA, ICARS, IDSA, and of course not the least Lancet, and of course the One Health Trust. And finally, to all of you, many of us have worked together for many, many years, and you're all the backbone of this AMR community, and you are also the best place to speak to how best to serve the millions of people who still need effective antibiotics. So I just want to take a moment to, you all have a glass of wine, and raise a toast to yourselves to thank you all for the incredible work that you do each and every day. Our hope as the authors is that you're pleased with the series, that it accurately reflects the best evidence on how to ensure that no one anywhere dies because of lack of access to effective antibiotics. Thank you. So next I'd like to turn to Dr. Richard Horton, Executive Editor of The Lancet, to deliver opening remarks.
Thanks very much, Ramanan. And it's always a danger having had 2 glasses of wine and an exquisite reception on a beautiful evening. It's very, very dangerous to, I need my glasses. Very, very dangerous to ask you to sit here for 2 hours to listen to our discussion. But there are very few issues in global health where there seems to be so much consensus, where there's so much powerful advocacy, and yet so little concrete action. What more, really, do policymakers, health ministers, finance ministers, even presidents and prime ministers need to know? The global burden of disease has shown that AMR is the 3rd leading cause of death after only ischemic heart disease and stroke. In a preliminary assessment presented at Dame Sally Davis's recent excellent Royal Society meeting, in a preliminary assessment of the 21st century global threats to health by one of our Lancet commissions, AMR came 3rd after the malicious use of artificial intelligence and obesity, and above pandemics and the climate crisis. A dominant issue at this year's World Health Assembly is, of course, pandemic preparedness. But what about AMR preparedness? For we are surely not prepared for a predicted 20% increase in mortality from AMR between now and 2050. So what must we do? The series that you're going to hear about today and is summarized in the executive summary in your bags, so ably led, and let me give my thanks to Ramanan and his most excellent team of authors, and also I want to give a name check to my colleague at the Lancet, Anna Matthias, who led from our side in an amazingly pressured sequence of edits to get this series into your hands today. This series sets out a manifesto for action. At its heart is the 10, 20, 30 series of targets that must make it into the political declaration later this year. But let me make a few brief observations as someone who's a bit of an outsider to the AMR community. First, almost 3/4 of instances of antibacterial resistance are attributable to just 6 pathogens. Yet only one of those pathogens, Strep pneumoniae, has so far been taken seriously. We need a plan, which we don't have yet, for the remaining 5 major pathogens that contribute to AMR. We, all of us, need to step up our ambition. Second, the AMR community must make common cause with other movements in global health. In particular, non-communicable diseases and child health. As the series makes crystal clear, AMR has a profound impact on prospects for newborn health and for those living with chronic diseases. But as yet, I do not see that effort to make common cause with other domains in global health. In meetings I go to about NCDs already this week, in meetings that I've attended about child health, AMR is never mentioned. We need to reach out to those communities. That means you as part of the AMR community. Third, I do not want to protest, as some have done at the World Health Assembly this week, against the participation of leaders from Big Pharma at the WHA. No, I want to hear from those leaders about what they are doing to increase the pipeline of antibiotics and vaccines to reduce antibiotic resistance and, indeed, Sally, and demand. I want to hold those leaders from Big Pharma accountable at the Assembly for their indispensable contributions to attacking AMR. Where are they? Fourth, AMR is an economic issue as much as it is a health issue. We have to reach out beyond the health sector to finance ministers, to make the case for action on AMR and to win their support. Again, I do not see a systematic effort to outreach to finance ministers. Too often, we just talk amongst ourselves. And finally, the current draft of the political declaration concludes with a promise to have another high-level meeting in 2029. Seriously? In 5 years' time? That is simply too far away. It indicates that there is no urgency, there is no accountability, there is no implementation strategy. We are being far too relaxed and complacent in our asks. Quite simply, at the present rate of progress, we are sleepwalking into a catastrophe. We have one opportunity this year for a radical course correction at the HLM. So let's seize that opportunity before we bequeath a shameful legacy to our children. This series is our joint contribution to motivating that necessary transformation. And as our friends in the AIDS movement, who actually understood the value of combining science with activism, used to shout, "Act up! Fight back!" Thank you.
So it's our pleasure right now to introduce the first panel for this evening. This panel will be moderated by one of the authors, Dr. Iruka Okeke. She is professor at the College of Medicine at the University of Ibadan in Nigeria. Our panelists today are going to be Dr. Noor Shamas from AMR Survivors Task Force from the World Health Organization. We have Dr. Mandy Cohen from the US CDC, and His Excellency Dr. Jean Kaseya from Africa CDC. Welcome. Yeah.
Thank you, Hector, and thanks all of you for being here. So, as was mentioned, and as appears in the first paper in the series, we have almost 8 million people dying of bacterial infections. And these are infections that without AMR and with total access to effective antibiotics just should not be happening. Almost 5 million of those deaths are associated with antimicrobial resistance, and 1.27 million deaths are attributable to antimicrobial resistance. In high-income settings where there are the best surveillance data, it's predicted that by 2030, the proportion of organisms that's resistant to antibiotics will have doubled if we do nothing. But the burden of antimicrobial resistance is really in the lowest resource settings, not just because of the bacteria that are evolving resistance, but also because these are the settings where there's a higher burden of infectious disease and a lower access to second and third line drugs, so-called reserve drugs. So there's some good news from countries like Nigeria, where I come from. The number of children dying before they reach 5 years has been dropping steadily over the last few decades. But we risk losing this progress because of antimicrobial resistance. While there has continued to be progress on under 5 survival, we now see stagnation in survival of newborns because newborns are commonly getting neonatal sepsis. And this sepsis is very commonly resistant to all the options that can be used to treat children of those ages. It's not just newborns, though. We're all susceptible to antimicrobial resistance. We all should care about it. And as we get older and frailer, we become more susceptible to infections and more likely to contract an antimicrobial resistant infection. Just 6 organisms account for between a 20th and a 10th of all-cause mortality in individuals over 65. And there will be more of us over 65 by 2030. The good news is that there's something we can do about it. And this is the reason why working on this series was so motivating. With interventions, as Ramana rightly said, with interventions that we already have, that we've already field tested, improving infection prevention and control, particularly in low-income settings, improving access to safe water and sanitation, and using childhood vaccines that have already been deployed will essentially prevent about 3/4 of the deaths that are attributable to antimicrobial resistance today. So please join me with the panel. We're going to talk about the antimicrobial resistance challenge and the impact of existing interventions. So thank you all for joining me. It's really amazing to be talking about antimicrobial resistance with these leaders in the field, and not just in the field of AMR. I'd like to start with you, Dr. Shamas. Your mother, you were in a position where you had to nurse her after surgery, and she came down with an antimicrobial resistant infection. Can you tell us what happened, please?
Yeah, sure. So for those of you who were at the Royal Society event last week, this is a recap. But I'm really happy to be able to share this because she consents to this and she wants everybody to know. Basically, she had emergency back surgery while I was at a conference focusing on ID and stewardship, actually. And after surgery, in a couple of months, basically 2 months, she started getting symptoms that basically everybody told her she has a problem with her back surgery, but it ended up being a urinary tract infection, which then ended up being a resistant infection that then became a recurrent resistant infection, I'm from Lebanon originally, and I'm an ID and stewardship pharmacist, so it was really difficult to all of a sudden realize that actually this can happen to you. You think you understand till you actually have to make a decision between the different antibiotics that your mother has to receive. Not to mention the problems that we had in finding the antibiotics in Lebanon during an economic crisis, a political crisis, and everything else that's been going on, and is still ongoing, of course. So in addition to all of that, I'd like to mention that my mother is actually medically literate, so she would be able to tell the nurses to wash their hands before they touch her. So eventually getting a urinary tract infection after all of that, catheter related, basically that's outside of the typical definition of a catheter related urinary tract infection, was really difficult to describe to her. Why is it that she has a UTI? As a woman, why is it that the antibiotics are not very good? Why does she have a recurrent infection? So all of this was really complicated, and even getting her to accept an ID consultation, an infectious disease consult, was really shameful for her. So it really helped me perceive the problem in a different light. So I'm very grateful for that. She's fine now. She has recurrent infections though, but yeah.
Thank you so much, Dr. Shamas. I think it really brings a human face to AMR. Many of us who work in the space of infectious disease, we're faced with these numbers, and each of these numbers is an individual who has to go through something like this. Dr. Kaseya, let me come to you. You head up Africa CDC. How does AMR impact the delivery, or how does it impact health systems, both at national, regional, and global levels?
Thank you. First, before knowing how it impacts, this AMR is impacting the health system, you must have data. This is the starting point. And I was sharing with colleagues yesterday, we had a nice dinner. I was saying that we lack data on AMR in Africa. And Kiko was giving us a kind of information on 90% of countries they have, I see Kiko, thank you. 90% of countries they have national action plan because they have data. But that 10% is mostly in Africa, where we don't have the national action plan because we don't have data. And now what we are doing is to sensitize, to put in place a surveillance mechanism to collect data and to start to use this data to conduct advocacy and to develop the National Action Plan. And this is the starting point. And we are at different levels when we are discussing with Western countries, because for us, we are starting at ground zero. And another one is about making people knowing that this AMR is not just impacting the health system, but it's impacting also our economy. You know, when you are discussing with leaders, I have to say to my leaders that in Africa, AMR is killing more than HIV, malaria, and TB combined. Then they wake up. They say, what is it, that one? And second, I say, that one is pushing you to bring down your economy because you are losing a lot of GDP. And that one is also helping us to sensitize leaders, to bring them to put appropriate policies and to start to provide funding while we are advocating for more resources, extra resources.
Thank you so much, Dr. Kaseya. Let me go to Dr. Cohen, because, I mean, you're directing the US CDC. And this is, you know, for those of us in Africa, this is an organization that heads up a surveillance program that, you know, we would like to emulate. How is the US investing in surveillance, and in particular surveillance of AMR?
Well, first, wonderful to be here. And I want to pick up on the theme Director General Kaseya was hitting on, which I think is very important. AMR, right, is not one single pathogen. And thus, investing in core capabilities is so critical, right? The system capabilities, data capabilities, lab capabilities, the talented workforce capabilities and the response capabilities. So whether we were having a conversation about TB or AMR, you would hear me start by saying that. And that means we at CDC have to be different in the way we are funding and supporting the work. And I hope you are starting to see that in our ability to support work. I think absolutely has to start with good data infrastructure, good laboratory infrastructure, talented workforce that is trained, and the response capability. So and the other part of this is the importance of the prevention side and making sure we have access to the right prevention. Obviously, big amongst those is vaccine. And of course, that is about childhood vaccines, and we have seen us take a step backwards from that globally since the pandemic. So, Richard, I have to take a little bit of issue when you say that you don't see the childhood community focused on AMR. We're talking vaccines with them all the time. That's an AMR issue, right? So I'm hopeful to link this together so that folks can see by investing in vaccines, they are helping on the AMR front. The chronic disease, our non-communicable disease front as well. I will tell you, our team thinks a lot about the pneumovax, right? It's a community that is experiencing a lot of pneumonias, but we have a vaccine for it, but we don't have as much uptake as we need to. So those are the ways in which I hope we are starting to link together, one, core capacity, but also the prevention activities that spans different conversations. So we're not just talking to ourselves about AMR, but we're talking about infrastructure capacity building so we can continue to make progress across a lot of fronts at the same time.
Thank you. I really do think that vaccines are a really nice starting place, particularly as we already have them. They're just under deployed. Dr. Shamas, let me come back to you. I mean, in my introduction, I mentioned vaccines, but I also mentioned infection prevention and control as having the potential to avert actually the highest number of deaths. How do we attain this in practice? And what should be done to ensure that fewer people get to face the unfortunate experiences that your mother had?
So a big part of this is getting everybody involved. So infection prevention control is something pretty relatively straightforward. So everybody is now talking more and more about behavioral change, but that's very difficult to implement if you don't have buy-in from different stakeholders in the community, in the hospital. So I think a big part of it is just getting everybody that is required to be on the table, at the table. So nurses, I don't know how many nurses are there in this room, and we talk about infection control. How often do we bring in patients and inform them? So I had to explain to my mother what hospital-acquired infections were prior to the surgery so that she can know what her risks are. So it would make it a lot easier to accept afterwards when it does happen because it's a risk. And so I think a big part of it is investing a lot more in behavioral change, making sure that also there are enough healthcare workers. So if we request from everybody to wash their hands when they don't have time to take care of their patients, how is that going to work? And especially with healthcare migration from my region, especially as well in the Middle East. So I think some basic interventions can go a long way, but people really have to be a bit less greedy and a bit more happy to share responsibilities with other healthcare workers, but also make sure that atypical, non-ID specialists are involved in the decision-making when it comes to IPC. Yeah.
Thank you so much. I think in Africa, I think we have very poor IPC statistics and also incomplete, as you said, Dr. Kaseya. And we also have a lot to lose from IPC failures because we just don't have the reserve drugs. We don't have anything else that we can use to deal with them. So, Dr. Kaseya, let me come to you and ask, how do we ensure that everyone around the world, including those on our continent, is assured access to this precious resource of antibiotics? How should we be thinking about access now with this crisis of antimicrobial resistance?
Thank you. I think you started by giving statistics from Nigeria and the decrease in terms of mortality due to children having access to antibiotics. But let me say, in Africa, my people are mostly dying because of lack of antibiotics. more than misuse of drugs. This is the first one. It means having access to quality product is a critical component of our plan. When we say that we are talking about counterfeit medicines that we have, you know, it's a combination of counterfeit medicines, poverty, as I was saying yesterday, because some people, they have a treatment for 5 days, but you have your neighbor who doesn't have treatment. You have to share the treatment while you are creating resistance. And we have also this issue of lack of appropriate quantity of medicines. Then for us to ensure access, we need, as Sally was making it nicely yesterday, saying we need to have a kind of pool procurement mechanism. And in Africa, we already create the pool procurement mechanism for our local manufacturing agenda. We need to bring affordable product that can be given to our population. The second one is to ensure that we are educating people on the best use of antibiotics. Because if communities, they know what to do and what not to do, that one will also help. And the third one, I think we are talking also about, you know, One Health. We are talking about a critical component bringing human, animal, and environmental sectors together. And when we discuss that, when we bring that, and when we bring appropriate and quality product to people, we educate them, we'll see that access will increase, AMR will decrease, and will save life.
Thank you very much. I'm told there are 2 other panels after us, so I'm just going to ask one more question, but I'm going to ask it to each of you. And essentially, the big message we have here is that, you know, we're pushing for targets. 10% reduction in AMR mortality, 20% in inappropriate use of antibiotics in humans, 30% reduction in inappropriate use of antibiotics in animals. And so each of you, in your opinion, what are the first steps that the global community should be taking to ensure that we actually meet these 10, 20, 30 by 2030 targets? I'll start with you, Dr. Cohen.
Sure. Not going to be surprised that in order to do this, I think we need to be investing in core capabilities and holding ourselves accountable for the lab capability, the data capability, workforce training, and response capability. Then we need to really focus on the prevention effort. Are we really putting our shoulders behind the vaccination efforts, both for childhood vaccinations, but across the board for vaccination efforts? And then I think your own slide said, we know what to do. We just have to do it consistently. I'm all for innovation, and I'm grateful for all of the innovation in therapeutics and diagnostics, and those need to keep moving forward. But if we just do the blocking and tackling, the things we know work, when we do it well, we're going to really make it a difference. So that's what I would say in order to meet those targets.
Thank you so much. Dr. Shamas.
I think similar to what was said earlier, access would be really important, so focusing on investing in access to antibiotics. So, and access to effective antibiotics means access to really basic antibiotics, but also really broad spectrum antibiotics. On the other hand, also I think thinking about education at a really early stage. If you come to prescribers and tell them after they've graduated that all of a sudden they now have to learn stewardship and what, you know, prescribing principles, that's a bit too late. So I think making sure that pharmacists, nurses, midwives understand AMR quite early on, and that's really missing. I had a hard time teaching AMR to a lot of people because it just was missing. And I think the last thing is just putting an emphasis on AMR being an ethical responsibility, basically. So giving appropriate antibiotics, and we were discussing this yesterday in a roundtable. Prescribing appropriately is an ethical responsibility. It's not just that you give an antibiotic just in case. When you harm someone, you're actually going against your medical training, basically. So reframing the argument in that sense could be really important.
Thank you, Dr. Kaseya.
As Richard said, we don't want to wait for 2029. Let us start today. And to start today, it's first let us educate our population. Let us inform them and build capacities of community health workers and health workers for them to start to notify any case and to better support our communities. The second one is to improve surveillance and lab system, because that one will give us data. This data will help us to conduct advocacy, but this data will help us also to track the progress we are making. The third one, we are talking about prevention. We have vaccines, we have WASH. Let us make it available for everyone. And the fourth one is access to medicines. I think if we do that, we can make progress. And we don't have to wait 2029. N'est-ce pas, Richard? Il fallait répondre en français.
Director Cohen, Dr. Shamas, and Your Excellency DG Kasea, thank you for being great champions in the fight against AMR, and thank you for the conversation on this panel.
It's time for our second panel, and the second panel will focus on expanding antibiotic, vaccine, and diagnostic innovation and access. Dr. Ramanand Lakshminarayan will return to the stage. He's moderating this panel. We have a slight change in our panel. Honorable Minister Sylvia Masebo couldn't make it today, but we have present today Mrs. Florence Journet, CEO of Aerobac Therapeutics. We also have Dr. Veronica von Messling, Director General at the Life Science Division at the Federal Ministry of Education and Research in Germany. Welcome.
So we have existing drugs, but that's not enough. We need new drugs. There are people who still die because of multi-drug resistant infections that are not treatable with any drug that we have. Just this past week, I had 2 of my friends lose their mothers to infections in India, which were resistant to all antibiotics. It just happened, 2 days in a row. And it just happens so much more frequently now, and all of you I know have these stories. And there was literally nothing that could be done for her. It was not because for either of them. It wasn't because their kids couldn't afford care or they couldn't pay for the best antibiotics. It's just that none of the antibiotics actually worked. Now, the Lancet series, focuses a lot on this issue of development of new tools, of drugs, vaccines, and diagnostics. Obviously, this is an area which is really important. Over the years, since 2017 to 2022, as you can see, there has been some increase in basic research, some in diagnostics, and some in therapeutics, mostly in therapeutics, I would say, but not sufficiently on vaccines, for instance. And I would say some of the other categories, we just haven't seen much of an increase over that period of time. Now, it doesn't mean that a drug coming to the market, and everyone here knows it is hard enough to bring a drug to market, but even when they do come to market, they're not affordable, even to patients in high-income countries. So these were prices of drugs in the United States, of drugs that were developed after 2000. You can see the ones before 2000, they're relatively inexpensive, but after 2000, they're all between $2,000 and $15,000. Now, if they cost that much, even if they were subsidized in LMICs, it's highly unlikely that they would come down to a price point where they could be afforded by people who really needed the drugs. So innovation was not sufficient. It was clear that access had to be built into the innovation agenda. The third is we're seeing a lot of new innovation in the sense of models for how to bring drugs to market. In fact, a lot of the money that has come into the new drug development space has come from the public sector, which is unusual before. Of course, we've always had private sector investment, and through entities like the AMR Action Fund, we now have significantly more research resources coming in. But entities like CARB-X and GARD-P, and then BARDA itself, have really brought money into helping with non-dilutive financing for companies at various stages. CARB-X, as you know, early stage, GARD-P and BARDA are sort of clinical phase, and later on, to be able to help ease this pathway. So one thing is obvious: the old model of drug development, which we've relied on, is just over. There is no going back to that world, right? There's just no going back to that world. Now, we're in a world where we're saying, if we don't have the public finances to be able to make this kind of model work out, then we're at risk for losing a lot of manpower from the industry, which is a serious concern. We're also at risk that we simply don't have new antibiotics when we'll inevitably need them in about 15, 20 years from now. And in some cases, like I just mentioned, we need them today, and we probably needed them 5 years ago. So a lot of these data come from the Global AMR R&D Hub, and which has been a very useful sort of accumulator of these kinds of data. But I think we now have a clear picture that we can't do business as usual. So what does this new world of AMR R&D look like? I think it looks like something which does involve public-private partnerships. In fact, nearly every antimalarial that was brought to market until artemethyl lumefantrine was developed by collaborations between Walter Reed, which is funded by the US military, and private companies, which brought a string of antimalarials to market. The Drugs for Neglected Disease Initiative has been successful at bringing drugs to market at anywhere between 50, 60 million euros to about 180 million euros. So there are models for reducing the cost of drug development, and this is important because the math is quite simple. If we develop a drug for $1 billion, there's no market or public incentive that's large enough to be able to repay that investor for the $1 billion they put into the antibiotic when you count up the time costs and everything else. However, if we're trying to figure out a way to do this collaboratively, where we're able to reduce the cost of drug development to being under 200 million euros, probably even much less than that, then we have a chance that we can then use these other incentives, and most importantly, that we can have drugs that are actually affordable, not just for patients in high-income countries, but also in low and middle-income countries. So I think the evidence is clear that we are going to need public-private partnerships, and I sense that where we're moving into is in defining the nature of these public-private partnerships and how they're really going to evolve over time. It's not a question of whether we will have public-private partnerships. I think that ship has really sailed. So, sorry, let me try to move. That was the last of my slides. So let me move back and say, I think this is an important conversation for us to have, going forward. There are many ways in which the public sector can actually be helping. And it is incumbent to make sure that even if drugs are accessible and affordable, we don't also forget the need for stewardship and making sure that they're used appropriately, regardless of where these drugs are used. So I have two excellent panelists. Unfortunately, the minister from Zambia was unable to come, but we have Dr. Veronica von Messling, and we have Florence Sejourné, who actually I have not seen in about 20 years, since she was running a very innovative company on how to develop these carbon molecules that would suck the antibiotics out of your gut, and very fascinating stuff when we first talked about it. I'd also like to remind you that about 1,500 people watching this on live stream online. So it's a pleasure to have both of you. So Veronica, if I'd like to start with you. So the Lancet series places a lot of emphasis on public-private partnerships because that's really a way to go. It's not just for new drugs, it's also for vaccines. You're also on the board of CEPI, for instance. So that itself shows we need this. And also for diagnostics, as FIND is that kind of a model. But the key is to be affordable to LMICs. How do you see this playing out? And Europe is obviously interested in developing drugs and tools for itself. But how can we do this innovation in a way that also helps LMICs?
Yeah,
I guess that's the question we're all grappling with, right? I think it's important to really kind of be honest about the different aspects of it, because AMR is an issue that affects every country. It is not LMIC or highly developed. It doesn't matter. So yes, obviously Europe has or Germany. I can only speak for Germany. You know, has a vested interest has recognized the problem and has a vested interest in developing tools and mechanisms to overcome this. And the idea that it has to be then also accessible to not just people who have a high resource setting, because it's not just the cost of the drug, it's also the way it has to be administered, the way the treatment has to be set up, all of that. I think that's very much clear. Where we are struggling is that having that balancing out this whole in-design thing. So are we going to miss out on a promising drug because in the beginning it is not clear how this could be given, let's say, not as an IV drug? Or are we going to say, yes, we are developing this drug, we are going down this route, and with the clear goal to eventually have this also be formulated as an oral application? I think when you break it down into something concrete, you realize that there is no one answer to this. I think it makes absolute sense we have the pipeline's not very full. It has gotten better. It's really hard to go from having something in the pipeline to having something in a pharmacy shelf. You know, it's an arduous way. And so that takes all our effort. And then making sure that this drug is not extraordinarily expensive is the next. It's not the next thing. It is one of the criteria of which project should be funded. Need has to drive this, and then also practicability. Is it producible? Can it be administered? All these questions, I think, and because it is so complex, and because it gets more and more complex as you go along, I think when you were talking, I was thinking that's our problem, that we define a problem. And then we say, yeah, and then we also want this. And then we also want this. And I'm wondering if part of being successful also is to say there's certain things that we are not doing, that where we are looking to partner with others who do that. So it's obvious that we need to develop new drugs, that we need to make sure that existing drugs are available where they are needed, and that we need to have the stewardship that makes sure that resistances are not being developed. But as I say this, there's not one single actor who can do all this. And I think part of us not advancing as fast as we wish is by us getting distracted, you know, and then the group that is actually able to develop drugs, and that's their core competency, starting to plan about stewardship, which is another group's competency. And what I really like about this series is that it gives us the opportunity to maybe sort that a little bit and see that each group advances as much as they can, rather than always saying, oh yeah, you have a new drug, but you know, it's not available everywhere, so that's not a success. I think we have to also celebrate those successes.
Perfectly, point well taken. So, Florence, over 80% of the companies working in this space are small biotechs. You yourself have run at least one, maybe even two of these companies. What's the chance that these companies will be able to bring new drugs to market without public incentives? And do you see any option at all to the public role in antibiotic development that that we haven't thought about?
That we haven't thought about. Is it working? Yes. Good evening, everyone. So yes, I'm actually the CEO of a biotech now called Orovac Therapeutics. That is an initiative from three larger companies, Boehringer Ingelheim, bioMérieux, and Evotec. And I'm the founder back in 2015 of a group of SMEs, the SMEs of Europe working on AMR called the BEAM Alliance. So I'm representing a little bit the the innovators here on the panel today. Well, I'm going to be very clear to your question. There is no chance that any SME can bring any product to market today without any public support. It's already demonstrated by the multiple unfortunate failures of companies who brought product to market and didn't make it because the market is broken. And well, the first, of course, public funding is required. However, as we all know, this sector is very, very high risk. So the ideal system would be to leverage private funding. That's the entire setting. And if we don't leverage private funding, it's going to be very difficult, right, for only public funding to make it, because as you all know, and that's actually something I pointed out from one of those papers, the chance of success from a discovery program to market is 3%. I mean, the numbers in the paper are 215 discovery programs go to 6 authorized, and I think the percentage from colleagues in Carbex 2 is like, you enter clinical, you have 7% chance to go to market. The cost, even though we make an effort, and you know, SMEs, we don't have a lot of cash. So we already optimize our cost maximum. So we have to share our analysis of our cost. Most of SMEs who've developed product have actually spent 300 to 500 million with cash. We know that because we raised fund in developing drugs. So it's not so far from your amount, even though it's not with capital. So we need to leverage private money. And to do this, I mean, there have been numerous economic reports. We need to fix the market and bring private money together with public money to make it. And fix the market comes from pull incentives. So again, there's been numerous years now of efforts considering those systems, those pull at multiple levels. The UK has done a great job at building a system, but they can't do it alone. It has to be for the entire HIC, so that, you know, this is the main message. Of course, public-private partnerships are an important part of the ecosystem, and especially for access. We've all seen that GARD-P deal with Shionogi on cefiderocol, and we're very much impatient to see how it's going to evolve, because this would be a very nice model to support access for new product. And on your last question, which is, do we have a different public role there? Well, already public partnerships and being before 29 as well, as soon as possible, propose a pull incentive world. I mean, that would work in all those high-income countries. Or clarifying the needs for all the countries is very important. Streamline the regulatory requirements across countries and regions, especially in LMICs. We'll talk about this. And of course, continue the funding of early research, because we all are very much based on early academic research for nice ideas.
Thank you. So note to GARD-P, don't screw this up on cefiderocol. We're all counting on you. And, you know, there's this famous question that someone asked Warren Buffett, how do you become a millionaire? And he said, start with $1 billion and start an airline. But he obviously never heard of new antibiotics, because that is a far more efficient way to get there. So let me then ask you actually a follow-up question, which is, the patients in need are in LMICs. Most of the economics for the companies are with patients in high-income countries. We're looking for subsidy programs, whether in the UK or wherever, to serve a small set of patients and then, you know, try to make the money off that small set of patients. From what I observe, the barrier to getting into the LMICs is simply that small biotechs have no knowledge base to go and, you know, sell to India or Brazil or, you know, all these other places. Can a strong access mechanism, and this is one thing that we call for in the paper, an access mechanism that we'll get to in a second, because we'll have Marika Windrox in the next panel. But from a developer perspective, if there were an access fund that was available to be able to get drugs into developing countries, would that be attractive to SMEs as a ready market that's stable and available?
I'm going to have a very pragmatic answer. SMEs are funded by private investors, so they are looking for profitability and success. So anything that will bring that will contribute. We're battling to put product on the market already in terms of challenges. So it's actually complex to integrate right away from the very beginning the LMIC access for small companies. We're trying to raise funds to
No, not for you to do it. Let's say somebody else were to come in and do it. Like Veronica
and
said,
that's the
access
beauty of
become-
public-private partnerships, similarly to what has been discussed before with GARPI. So yes, I mean, of course, this would help, but the challenges are already in delivering, decreasing risk and getting success. I want to point out that actually, if you look at the latest clinical studies for the last 10 antibiotics to market, 30% of patients have been recruited in LMICs in Asia. Exactly. So, I mean, I've read that we should go more to those countries. It's already the case. Huh? We're not, I mean, one of the studies on one of the most recent product put on the market by Entasis, they had one patient in the US. All the rest was, So it's important to point out that it's already, this communication is already there. SMEs, we have limited resources. So for sure, an effort for access would be welcome. First, the clinical trials, and we know the Advanced ID program that is led by David Patterson is really interesting. But our main challenge is actually to bring new products already to a level that is acceptable for men and showing efficacy and safety.
Great. Thank you. So, Veronica, switching gears a little bit, we're talking about small molecule antibiotics. But what role do you see for public funders outside of the traditional, small molecule antibiotics? We have a box on bacteriophages. We have other sort of avenues. Personally, if we were still dealing with infections in terms of treatment using just the small molecule approach in 30 or 40 years from now, that would not be a good thing. So what is a public funder like you doing in terms of making those sort of out there bets?
Yeah, so in the discovery space, we fund, and I think most funders have investigator-initiated or investigator-driven programs that are competing with others and peer-reviewed by their own peer group. So that is good. So of course, what it does is, on the one hand, it reinforces current ideas, because that's what is considered to be state of the art. But in our experience, that also always gives spaces for, let's say, out-of-the-box innovative approaches. The challenge often is to get to the transition from discovery research to development research, because the discovery space is wide open, and a lot of hypotheses can be tested. And then when you think about, so if I actually want to use this, what does this actually entail? Then the whole drug development system is very conservative, for good reasons, because it is all about risk versus benefit, and the risk is, but there again, I think new antibiotics have an advantage, let's say, compared, for example, to vaccines, or at least prophylactic vaccines, because you want to treat somebody who is gravely ill. So you have, with respect to risk and safety, you have actually an interesting space, and that is where new therapies like phages, like therapeutic vaccines, like immunomodulatory approaches, all of these things actually come in. And I think one space where we see this happening is in the area of septicemia or sepsis, where a lot of the immunomodulatory molecules are being evaluated, and some with great success. I think the therapeutic vaccine space is interesting, especially for more chronic infections, and there's a lot out there, and we fund this. Where we struggle really is then when it comes to get this into the commercial space, because again, it's exactly like my neighbor says, you need to raise the funds, you need to convince people with money to invest into this endeavor. And I think the challenge we have with antibiotics is that we want the companies to develop a product that we then don't want them to sell. And that's a big difference to many other drugs, because it's not a rare disease, right? A rare disease, at least I have patients, and if I have a drug, then those patients could be treated. Here, I have a reserve antibiotic. I have a new entity, so essentially I'm asked to go all the way and then leave it on the shelf. And that's why I agree that the business model has to be looked at. And also the ways we think about licensing these drugs, I think we should look at. Again, that's not a research question, but that is clearly, these are very important questions we have to find answers to if we want to have it reach the patient.
No, absolutely true. So when we think about ways of, again, reducing the cost of development, whether it's in the small molecule space, so I'll tell you, when we were writing this particular chapter, there was always the tension between, some people who come from the sort of the clinical scientific space who say, oh, but the drugs that are being developed are not innovative enough. But on the other hand, the reason they're not innovative enough is what Veronica just said, which is, do you really want to be on the cutting edge of innovation when you can't make money even off of a very safe bet without really pushing the boundaries there? So there's a risk-reward trade-off, and we are not rewarding risk-taking very much at all. But one thing we could do is at least set up platforms. One of the things we call for in this paper is to look at platform services for CMC, for quality, for for things like clinical trials, for trying to figure out ways in which there can be shared services that are available to a range of SMEs, so that we're lowering a lot of their costs. I know that both GARDP and CARB-X are trying to do this as well. How valuable is that to SMEs, and is this something that we can be investing more money on?
Yeah, I think all what we're saying, first of all, is complementary. Huh? I think it's something I want to point out. We talk about pull incentive, we talk about public-private partnership, and we talk about service. I mean, everything is complementary, and we shouldn't oppose any of this. Regarding platforms and support, for sure, regulatory services around accessing LMICs is important. Those are all different countries. It's complex. FDA, EMA are really clear. SMEs know how to handle those ones, and Japan, Canada, a few. But the LMICs is, so that's one action. I mentioned the clinical. I think having access to the right patients in the best way possible with the right quality would make sense for sure. For the CMC, I have an experience myself developing several drugs, which shows that every factory, every manufacturing site has specificities. The type of drug, small molecule, a chemical, a peptide, a protein, then the form, the drug product, that's the drug substance, the drug product, the formulation, pellets, pills, whatever. When I've been looking for manufacturing site myself for the drugs I've been developing, I had like 4 or 5 choices worldwide, 6 worldwide, not so many. So on the CMC part, I wonder what would be or 1 or 2 manufacturing sites and technology you would bet on to be able to support. So it's a question of wideness of technology, and if we look at others, even phages, well, they have a huge challenge for CMC. So maybe for small molecules, but even there, you need some specific equipments for scale-up. So I think it's theoretically, I wish we could say, well, let's make some nice, cheap manufacturing sites, just like they do in textile or something, I don't know. But we unfortunately don't use the same equipment, the same techno, and it sounds to me a little ambitious, so that it fits to the form of the new drugs we would develop. But regulatory and clinical, for sure, it makes a lot of sense. And yeah, the CMC, I'm happy to further discuss and give some concrete examples. And again, reducing price of manufacturing. Keep in mind, I mean, I wish I would have done this analysis, but probably it's not known. Looking at all the drugs manufactured and developed in the last 10 years, not all of them are cheap to manufacture because they're big molecules, or they have a lot of synthetic steps. And chemists always try to make it cheaper. Huh? It's funny how you think maybe industry wants things to be expensive. No, we are trying to make things cheap all the time, and especially SMEs, indeed. And sometimes it's difficult to reduce the number of steps to be able to reduce the cost of the manufacturing.
Right. No, that's so useful, because I think some of the drugs that are not making it on the market that we know, companies that have gone under, is precisely because the number of steps is too large, and so the cost of manufacturing is too high to then justify getting the drug out. It's really important. We'll also hear from Dr. Nakatani at the very end on this issue, which I'm sure she'll come back to on access, but I want to put you, both of you on the spot, which is, we all talk about regulatory harmonization. I mean, at one level, you just think, people are people, we should be able to get drugs into multiple countries. The analysis that a few of us in this room, Kevin, Jan Arne, and I, we had a student from Norway working on this a few years ago. She found that more than half of the drugs that had been developed between 2000 and 2014 didn't make it into more than 10 countries. Why? Because it wasn't worthwhile for the company to go and try to register in more than 10 countries. Now, if that was possible to be done, now we know we do that for other drugs. We do that when there are, the Global Fund has programs for access, say, for HIV drugs and stuff. We're able to do this. What is the big opportunity if we had a plan to do this within the next 2 or 3 years and we really put our weight on easing the barriers to get drugs registered in as many geographies as possible? Because we can talk about affordability and access, till the cows come home, but if we don't have the product registered, what's the point of affordability? What can we concretely be doing here so that we can come back, or maybe we can even put this into the zero draft or to the UNGA draft to say that we really need this harmonization in a way that multiple countries can all have access to the drugs at the same time. So I'll start with maybe from Veronica and then come to Florence.
That's one of the to-dos for the sovereign countries, because it is the responsibility of the government to keep their people safe. That's the basis of the regulatory systems, and countries do that, and they come up with these regulatory agencies. And if you look at Europe, having the EMA, which is so everybody complains about it, but it makes Europe a single market. It makes Europe attractive for companies because
we like it.
No. But I mean, so nobody holds any other region in the world back from doing something similar. And I hear that now the efforts in Africa are advancing rapidly to have something similar. South America, Southeast Asia, these would be areas, regions where such an organization would be a huge pull incentive.
Yes.
Because you have buy one, get like 50 or 26 free. And that is really, there's nothing we as individuals can do. This is something that the governments, that the states can do. And yes, you relinquish some of your autonomy, but you gain essentially this pull incentive. And that was, I think, what drove, among many other things, what drives the European thought process. And I think that is what hopefully drives the African thought process. And hopefully other regions will look at that. But there's nothing that can replace that, because regulatory harmonization has to be done by the state actors, by those responsible, because ultimately I think I'm always advocating for the regulators, because honestly they are the last stop, and then it's the patient. So they look at this drug and they ask, is this drug going to do more good than harm? And is it ready for the market? Can it be produced properly every single time? And if the companies can demonstrate that, they will get their license. And that's a huge responsibility, and no wonder they are careful, and no wonder they have lots of questions. And so the point of harmonization is really where we can grab that process, because that would mean if I have gone through the process in region A, then I have a really good likelihood that I will also succeed in region B. I will have another quick point here, because there's another vantage point, and that is in Europe and also in the US, we have an option for rare diseases. And I keep saying this. and there's definition what a rare disease is. And at this time, multi-drug resistant infection qualifies in many cases as a rare disease. So antibiotics that would, or any type of therapeutics that would target these diseases would qualify for that particular track, which means that you can have licenses early on. And that type of, and that is, I think, a tool that we haven't really looked at enough, that we could explore and that would make access possible at an earlier developmental stage, with all the risks that are associated with that type of licensing. So I think that is another angle to explore. But the primary angle is harmonization, and that is what governments have in their own hands. And it's hard, but it's doable.
Thank you.
Yes, I agree on the harmonization on the regulatory part, starting by EMA and FDA. And then
I don't want to say that, but you know, we don't have to point at Africa. That was, you know, that's
but the
first step.
The rest too. Well, we have to keep in mind that even in high-income countries, and taking Europe, even the access is very different country by country. So there's no harmonization with access. And if you look only at Europe, those new drugs are not available everywhere in Europe. That's even a European question today. So it is a significant topic, right? At the end, I'm sorry to say that moving forward in a country means investing. You need to invest to be able to go through those steps, regulatory-wise, but then allow the access of the product, propose it to pharmacies, to hospitals. This costs money. Who pays? And at the end, companies, when they are facing their launching strategy and marketing strategy, they look at, okay, how much it's going to cost me and how much it's going to, how much return I'm going to have. And again, I'm coming back to pull incentives, because the entire rationale behind pull is to delink sales and get reward without having the volume and the sales, and have the high-income country pay for innovation. So that maybe with LMICs, we could do things differently too. So yeah, I think definitely I understand regulatory is a big one. Access is another one for sure, even in Europe. But the who pays for what, and building up a pull principle globally with high-income countries would enable us, to be more free to find solution and liberate the access as well at the same time.
Well, but as you said, we're setting up all these barriers, and then we want the cash to overcome the barriers. Whereas if we actually reduce the barriers, we don't have to spend, so much. Like in the US, we're asking for the money for Pasteur, but that's because we're also trying to overcome a whole bunch of barriers which we've placed for companies to actually be innovative.
I would think it's more the risk.
It's all the risk, exactly.
That is covered.
Yeah. So as we draw to the end, we have a couple of minutes in case anyone wants to have a question or a comment. We have a microphone here. Anyone, any comments on you've obviously had a chance to look at the executive summaries only, maybe not the papers itself. Okay, well, if there are none, thank you so much. Let's give the panelists a round of applause, and I'll hand back to Urta.
Thank you. Raman, did you get them? Yeah, no problem. All right, so here we transition to the last panel for tonight. But despite the fact that it's the last panel, there's plenty of time to talk with each other and the panelists afterwards. So this panel will be transitioning towards the path to the UNGA 2024, governance and targets for sustainable access to effective antibiotics. It will be chaired by Professor Mark Mendelsohn from the University of Cape Town in South Africa. And our panelists today are Dr. Marieke Winrooks from the Global Fund and Dr. John-Arne Rotingen from Wellcome Trust. Welcome, and thank you for joining us today.
Okay, thank you very much. Well, the sun is going down. Your alcohol levels are going down from your pre-meeting drinks, and your glucose homeostasis is going bananas because you haven't had enough food recently. So, but we have a fantastic couple of panelists here to really now move towards the essence of where we're trying to get to, which is the action part of this. Before I make some initial comments, I'd just like to pay tribute to all the co-authors on the paper I led, paper 4, and particularly also to paper 2 and Joseph Lunard, who's in the room, who led paper 2, much of the modelling, and to all the other modellers for the evidence base behind what we're going to, or what we're putting out in this Lancet series. So, for a successful political declaration, which we hope the September declaration is going to be, we need 4 things. We need political will, we need funding, we need accountability, and we need targets. So there's definitely political interest. We're all here. We've got a meeting at the UN General Assembly. We have the opportunity. Whether there is unified political interest and enough political interest also needs to be questioned. The G7, G20 have been really at the forefront of pushing the agenda and moving forward on antimicrobial resistance. The G77 as the Global South's main voice, which is where I sit in the world, has been perhaps not vocal enough and not active enough. And so we need to bring everybody together, not just the G7, G20. Political will and interest needs to be across the board. We need accountability, we need funding, we've had some discussions already about this, and we need targets, which is the main focus of paper 4. And we've heard already that the investment, the number of deaths that we're seeing, the impact of antimicrobial resistance on the world's population versus, in comparison to some of the other major health and infectious diseases risks, the mortality is much greater, but the actual amount of spending going towards this is sort of inversely proportional. The crux of this paper 4 and the crux really of what we're trying to get to is obviously sustainable access to effective antibiotics. But it is also to propose these 3 global targets for mitigating antimicrobial, antibiotic resistance. 2 of these, the target of 10% reduction in global deaths and the 30% reduction in inappropriate use in animals, are currently in the 0 draft. The second of them, the 20% reduction, global reduction in inappropriate antibiotics in humans, is not yet in there. Parts of it are the 80% access antibiotics for a national level target is correct. But you can't just have that as a target for reducing inappropriate antibiotics, because if a country wanted to, you could just increase the amount of access antibiotics inappropriately being prescribed, and you would increase your percentage. So it's not enough, and we would call for the inclusion of the 20% within the political declaration. And the important thing about these targets is that they are achievable with the current tools in our toolbox. We're not looking to anything new, we're looking to scale up of what we already have, and they are achievable targets. So we've talked already about the importance of infection prevention, these critical 3 areas of infection prevention control, the access to clean water and safe sanitation, and vaccination in impacting on antimicrobial resistance mortality and getting towards, if we can scale up these interventions, getting us to, not only towards, but arguably past the 10% reduction rate by 2030, based on obviously the 2019 levels. We also know that we can get down with using these interventions down to that 20% reduction in inappropriate antibiotic use in humans. We know the effect, and all the modelling that Joseph and his team and others have done show us that this is achievable. So the establishment in terms of accountability, we need the establishment of an independent scientific body to expand the evidence base. And it was wonderful to hear at the London meeting at the Royal Society the commitment of from the United Kingdom and from Saudi Arabia, and hopefully also from the European Commission, in funding an independent scientific panel. And we need investment and increased funding in infection prevention measures, as we've discussed. So with those initial comments in mind, I'm going to join my distinguished panel and transition to another microphone. Fantastic. The good thing about having a smallish panel is that you can see the targets better. So, wonderful. Thank you for joining us today. So, maybe Jonna and I can come to you first, if that's okay. So, one of the pillars we've been discussing of success for the political declaration and the work that will follow is accountability. So do you support the formation of an independent scientific body for antimicrobial resistance as is outlined in the zero draft of the UNGA political declaration? And how do you see it increasing accountability?
Yeah, thank you. Actually, can I ask a question to the audience first?
You can,
because I was just thinking of Richard's comments in the beginning. And political will was one of the issues here, and you say we have political will. But how many of you came to this event really not knowing a lot about AMR? You're not a part of the AMR community, but you wanted to learn more. So how would you identify yourself as non-AMRist? Okay, we have two. And I will come back to your question, Mark, sorry. But my point is that I've had some conversations with either political leaders or bureaucratic leaders who are really not AMR people during this World Health Assembly. And they understand intellectually the problem, but they don't feel the problem. And they don't hear the problem. And even the numbers, they understand the numbers, but still. So we have a job to do. So how does that translate to the scientific panel? Because I am supportive, Wellcome is supportive of this scientific panel. We even made our own sort of report as a sort of appendix maybe, or whatever, to the Lancet series. No, we have actually 3 asks for the high-level meeting, and one ask is really on the scientific panel, because there is a need for independent advice to governments, to countries, but also to the agencies, the organizations working in this space. And we know we have the quadripartite agencies, so the 4 agencies working in this space, which is key, but they have their different mandates and responsibilities. And some of the issues around AMR is really difficult because it's trade-offs. It's trade-offs between different sectors and different needs and different ways in some way to maximize human well-being. But where I, as a WHO and human health person, would say you should maximize only health from a human perspective, that there are other issues as well, as we know. So I believe that is a part of the accountability, but just a part. It's a necessary condition. It's not sufficient. Political will is, in addition, needed. And then that needs to be linked to some level of targets. So it's good we have targets. Reductions in mortality is something everyone can agree to, I think. The consumption targets much harder. And I think we may need to let governments develop those themselves, but in a peer way of doing it. Like in a way, as we know, for climate, the Paris Agreement is country-based targets, but then when they have sort of committed to that targets, they are really channeled through a common accountability mechanism. And that is our third ask from Wellcome Trust, the common accountability, the way we are actually checking each other up as governments. I'm just transitioning from government, sorry, so I was in a government. So governments are, in general, challenging each other. But to do that, we need political will, and they need to hear the voice of people and society. Yeah. And we don't have that.
So, I mean, these targets, the 10, 20, 30 targets, are global targets. So clearly each country would need to see where their targets and how they would help to reach that. And we appreciate that there are going to be some countries clearly who are going to need to increase, and as we've heard, the deaths from lack of access. So clearly it is at a country level. But thank you for those thoughts. So, Marika, maybe I could turn to you.
Can I first?
Oh,
Because
please.
It's just
Carry
the two
on.
of us, so I think we have.
Yeah, you can.
We don't
Yeah,
have to
absolutely.
stick to the 2 minutes.
You don't mind, do you?
We don't need him.
No.
I'm just going.
No, I just I wanted to reflect on the independent scientific panel, and I'm all for it. But I've been engaging in discussions on and off on AMR, I think, for the last 8 or 9 years, and so often meetings then concluded we need more evidence, we need more data, we need a new commission, we need a new group, we need another meeting in 2029, and yes, we can always have more evidence and more data, but I also think that we have for now sufficient evidence to start moving, and somehow that level, that urgency is not there. And I'm absolutely baffled. So I fully agree with what you said, but I think we also need to think why in the AMR discussions, we could learn from the HIV response where people did not agree that we need more evidence. When we had I'm sorry, I'm going too long. When there was the high level, the UNGAs on HIV in 2000, treatment barely made it to the outcome declaration. It would not have been for activists pushing to get it, it would not have happened. So let's start pushing. You can.
Can I go? Can I?
You can go to your question now.
That's very kind. Thank you. Yes, I mean it's interesting. In terms of the activism in South Africa, where a lot of the activism obviously came from, it was largely in response to a government that was denying and suppressing, which we're not. Hopefully nobody's denying and suppressing, but they're certainly suppressing the importance of AMR, perhaps. But let's look with a happy vision. Okay, so let's say that the 10, 20, 30 targets make it into the final political declaration, and shortly thereafter you get a substantial amount of funding. How are you and the Global Fund going to ensure that we meet those targets?
I think if I just look at those targets, they would not be entirely sort of relevant to our mandate. Our mandate is HIV, TB, malaria. We do a lot in resistance. AMR is very relevant for us. I think it's to meeting those targets. It's first and foremost, it's a government commitment that governments have to commit to, and that will have to be monitored. So I would find it more difficult to see how the Global Funds, within our current mandate, what we would do to have the accountability in those targets.
But you've seen, and we've already said, and it's been said a number of times, how the current mortality and the threat from antimicrobial resistance far outweighs your traditional areas of funding. Is it not time the Global Fund pivots properly towards AMR?
I think if the funding for HIV, TB and malaria would not be there, would be at similar levels as AMR, mortality rates would look very differently. So I think we'll have to take that into account. I don't think that the Global Fund is going to be an AMR fund. If you work, just to start, and I'll come to your question. If you work on HIV, TB and malaria, there's really no way to not be super concerned about resistance developing. And that has been, from the start of the Global Fund, something that we have been monitoring, that we've been trying to prevent. And when we saw that resistance was increasing, we've tried to respond to it. And so just the whole thinking about resistance, the concern about resistance, and how do you then respond to it is absolutely core to what we do. And also AMR is a risk to people living with HIV, and especially for people living with HIV and TB. which I guess is not dissimilar to the risk that people living with NCDs are running. So it's absolutely something that is important for our mission. We do invest a lot in what we call resilient and sustainable systems for health. It does include community health, which is very important for AMR, and those do include investments in IPC, in integrated disease surveillance, in setting up lab systems. And really we've made a shift where we moved away from disease-specific system strengthening to really try to be much more holistic, like strengthening lab systems overall, and in the health workforce with a very strong focus on community health workers. And all of these health system strengthening activities are absolutely critical for AMR. If you would ask me, will the Global Fund support national action plans? The answer is no, I don't see that happening. I heard earlier that 90% of countries do have national action plans. When we were at the multi-stakeholder meeting hearing in New York, Tedros in his video message, he mentioned that only 11% of countries fund their national action plans. So that's a big issue. And it's going to be really difficult to convince international donors that national action plans should be funded if the governments themselves don't fund it themselves. So I don't see that happening, but if you just the sort of health systems interventions that we are supporting and scaling up should absolutely be part and parcel of at least the health segment of national action plans, and we'll continue doing that and hopefully can scale up. And Ramanan is pushing us all the time when it comes to access. But of course, we do have a lot of experience in how you can increase access to commodities for diseases that most predominantly affect poor and marginalized communities in low and middle income settings. And if you look at the markets for HIV, TB, and malaria commodities 25 years ago, just before the Global Fund was established, it was not that different. So we absolutely do have expertise and experience that we can share on how you sort of help create a market that is innovative, that can scale up, that's commodities that are affordable and accessible. So yes, there's a lot we are already doing. There's things we can do more, but I don't think we're going to be an AMR fund. Sorry.
That's disappointing, but not disappointing. But I thank you. No, I really appreciate your comments. I mean, and health system strengthening for all of these things, and the benefit of all these interventions in other areas is critical. But as Dr. Horton said, we are sleepwalking currently, and increasing surveillance is important, but we're showing you with this, in this paper and in this series, what impact you can have in certain areas in terms of infection prevention. Now, Jonana talking about that, and I'd actually be interested to get both of your views on that. Clearly, the funding for that is one part of the equation. So the funding for the infection prevention. But what needs to be done at country and international level, do you think, to translate the money into action on infection prevention? How are we going to scale this up?
Yeah, so action needs to happen on the ground. National action plans is a tool, is a way to gather around a common plan in countries, but it needs to be driven by people in hospitals, in communities, and actually being an integrated part of a public health response and a health system. That's very easy to say, but it's actually no other solution really. We cannot create a vertical program to sit next to someone who's have really reduced disease burden through vertical programming. I don't think we can create vertical programming on infection prevention and control and WASH. We need to put that responsibility in the hands of countries, their governments, their citizens, their health personnel, and civil society. That's difficult, but I don't see really another approach.
But we sort of
another approach would be really paternalistic in some way. We know better than what your priorities are and what your needs are. I think in the end we need to come down to the point that countries need to find their way. The international system can support and make it easier, can develop global public goods, can help with demand aggregation, pool procurement, can help with financing. But in the end, I think we actually have done too much of globalization in some way in global health over the years. We have crowded out domestic finance, quite solid evidence on crowding out of domestic finance on health. And there is a need for governments and countries, their populations, to take a responsibility to invest in the social sectors. It's health, it's education, and it's social welfare, and this is a core part of it. This is extremely boring, and this is probably a political statement, but I think it's reality.
Yeah. Well, it is an important statement, but it is status quo in a way. We've been asking for this and pushing for this for years now, particularly since 2016. So you are from a public health background. You now become public health supremo. How are you going to actually change the needle? How are you going to push this forward?
Yeah, and I was the public health supremo on infection control in Norway, and
now
that's
it's the world.
Pardon?
Now it's the world.
Now it's the world. No, not at all. But it is a challenge because, and of course, Norway is a very different context than the low and middle income countries we're talking about. But really, just to get politicians to understand that we need to support preparedness, response capabilities, boring surveillance, and so forth. That's not a patient screaming or going in media on needing a treatment and the most expensive cancer care or so forth. So it's a political hard job, but we need to just do that hard work together, and that's why we need more of a thinking on how we can mobilize people and the movement.
Okay, so exactly that. So, Marika, coming back to you and the HIV example, we talked about the role of civil society. I mean, isn't it time to light a fire? I mean, really, you know.
I'm an activist always. No, absolutely, and just building on, so sorry, I'm a little bit ill-disciplined. Building on the IPC in the WASH investment and why so little is happening. During the pandemic, we had a couple of meetings too, because we were thinking that maybe this is the moment where we can really make the case for a scale-up and WASH in IPC. Because if this is not the moment, when will it ever happen? And very little appetite somehow, and I think it's maybe because it's not sexy, because it cuts across different sectors. I don't know. No, I think it's absolutely it's time to light the fire. I think one thing we really need to reflect on, what's the narrative on AMR? Because as Dr. Kaseya said, in the African continent, still more people die because of lack of access to antibiotics than because of inappropriate use. And in the past, the message, I really appreciate that there's now a much stronger message about access. But in the past, the message sometimes was that so people in high-income countries are concerned about AMR, and that's why it should be priority for everyone. And that's a way of framing global health security as protecting people in rich countries. And I think we'll have to change the narrative. It's about equity, it's about access. And because if we don't, and we've seen it, how things really went dramatically wrong in terms of inequities during the pandemic. I'm not so surprised that the G77 is so quiet, because they might see AMR, this is another imposed priority on us, because it's a problem for people in a high-income country. And we really have to shift that narrative and explain this is a global public good. It's a global problem that we need to collectively address.
Thank you. Jonana, you wanted to come
Yeah, no, I agree absolutely that we need to shift this to be about making sure that we can prevent and treat disease. And of course, there's no competition between diseases. At the same time, there's a tendency, of course, to emphasize what we care about. And bacterial infections, we haven't really, I think, fully understood. And back to the evidence, actually, the evidence was not that strong and out there. This is the beauty, because I'm an infectious disease epidemiologist, which made me interested, is of course the dynamic nature of infections, because the reason that balance is like it is today is that we have heavily really invested and gone together in partnerships around the 3 big infectious diseases. If we hadn't done that, of course, the disease burden would be different. That's why it's so difficult to sort of compare diseases, in particular infectious diseases, compared to non-communicable diseases, where the risk is much more stable and constant. Infectious diseases, my infection is, and I'm not infectious even though I cough, I'm in improvement. But my infection is a risk to Mareke and so forth. And so the success of the interventions we have been able to do as a global community on TB, AIDS and malaria have contributed to the relatively much lower disease burden today than we had.
Absolutely, and we've done it, and now it's time to turn attention to something
but,
that is
but my point,
I would put to you.
Yeah, but my point, I don't think that... I think the world, the political leaders are not willing to put another record on the album. To just go and do the same things once more. I think in global health we have been so fortunate in some way that we have been able, after year 2000, to really focus, and the MDGs help that in some way, focus on some very targeted areas and manage to mobilize substantial resources to global health and by a very focused vertical approach. I don't think there is appetite. I don't think it's a sustainable strategy. I think we need to now maintain, definitely, and increase the level of investment in global health. But I think we need to make it more relevant to the domestic agendas and the needs. And at the same time, do the necessary investments in global public goods. We cannot, the hammer doesn't work anymore. We have more than nails that we need to fix.
Little bit of hammer, little bit of carrot, little bit of stick. Before I ask our last question, I wondered, I think we're being joined tonight by the Director General for Health of Malta. Is Karen Vincenti in the room? Karen, thank you so much. I wondered if we could just get your thoughts. Thank you for joining us. And what does a successful UNGA political declaration what would it look like from Malta's perspective? Sorry.
I'm actually Director for International Affairs and Policy Development.
You'd make a wonderful director.
Public health doctor with an infectious disease background. So, yeah. Okay, 2 minutes. So, I believe that Malta's vision is actually a shared vision by many people in here. We would like to see a bold, concise political declaration that does really look at the evidence, and the numbers and the testimonies really speak for themselves, and translates that into tangible action across sectors beyond health by the politicians across government, because we need all sectors on board, and also filtering down through public health, policymakers, and at the clinical level and on the ground, and everywhere. Because if this doesn't happen everywhere, we're going to be back to square one. You've probably all seen the Zero draft. After months of listening to stakeholders and member states, we've tried to frame the most important elements to avoid having a long Christmas tree. However, we really do need your help. The draft is now in the hands of the member states. So, yes, please do light a fire, because you understand the importance. We need to make others, so please do continue to raise your voices and continue to outreach to others, so that we can really make this a meaningful declaration. We have had good feedback so far. We want to make sure that we do include the targets, and thank you to the Lancet for the timely publication of this series. as you said, 2 of the targets are already in the zero draft. Let's make sure that the targets stay there as much as possible, and that any additions to the draft are actually improvements and not regression. So the co-facilitators are receiving written comments from member states up to the 30th or 31st, I just have to check the date, 31st, written input by 31st, and there's a stakeholders meeting between the 30th and the 31st. So please do make contact, follow the progress in New York, transmit this to capitals, and let's light this fire and let's do this. Thank you.
Thank you very much. Thank you so much. Thank you to Malta and of course Barbados for the amazing commitment and all the work that's been done. And thank you for those views. So very quickly, just one last question. You don't have to look worried. Why are targets? Why are the 10, 20, 30 targets? I'm going to say that. Why are the 10, 20, 30 targets by 2030 for antimicrobial resistance so important to move us forward towards mitigating the AMR pandemic? Marika first.
I think targets can really help to frame a very simple message. And so it's the accountability, but also the 10, 20, 30, it's a very simple message that can help you to get the message across. So as long as there's funding attached to it and a mechanism to hold countries accountable, I think it's fantastic.
Yeah, what gets measured gets done, and at least it provides that convergence of focus, and it's a way to communicate clearly what we need to hold countries and governments accountable to.
Wonderful. I hope you'll join me in thanking our 2 wonderful panelists, and thank you.
Thank you very much for that engaging discussion. It's our pleasure now to ask Dr. Yukiko Nakatani, Assistant Director General at the WHO, to give some closing remarks. Thank you.
So good evening. So thank you very much for this convening this important event. Ramana, you're back now, so thank you. I'm starting my remark. So thank you very much for the organizer for convening this important announcing event addressing the AMR response to accelerate our response in globally. And also, I would like to thanks to the speakers and the participants joining today here for your efforts in your place, where you are working, and also this excellent output or the findings from the evidence to accelerate our response really. Then I must take stock of those important and impactful the findings from the Lancet this study today. Then I need to advocate those data to our bilateral meeting during this week. So thank you very much on that. So I need to do those things. So as the acting ADG for the AMR division. Then what I need to say. So I think most of the speakers underscored we must act now. So otherwise, it's the lives losing in new generation. That's a very critical message for us. And also, we must act now, this critical moment, and especially this year and this week, because the World Health Assembly hoping will adapt of the new resolution on the priority our priorities in human health sector's actions. Coming days or the Thursday or hopefully before Friday. And the other zero draft just presented to the high-level meeting. It's circulated now in the across the member states, to waiting for the written inputs by the 31st of May. So this week is crucial. And also pandemic accord. INB discussion still ongoing, and also we need to finalize those negotiations to have the pandemic accord to strengthening our preparedness for the next pandemic. And then AMR is the one of the cause for the next pandemic, but the AMR is not pathogen itself. Then, but the AMR is different from the other pathogens because the preventable, if we can act now. So that message is for important, I think. So that's why, so act now. So I echo through all the speakers today. Then in the conclusion, I want to mentioning the access, because my original responsibility is the ADG for the access to the medicine and health products. Then access meaning not only the accessibility. Access, the word is access, including the full spectrum of the access issues, accessibility, affordability, and availability, and appropriate use. And then currently, not but we put on the quality assurance on the health product. The quality is also important because of the substandard, falsified medicines. It affects us the $30 billion per year in the African countries. That's the estimation, but this kind of the impact to be occurred. Then that's part. So I wish you having your voice to the bringing the many of the member states and in your praise and the moving forward very faster within the months. So that's my hoping. So I hope so we can have the concrete action-oriented commitment and also evidence-based target in the declaration in high-level meeting. So we really hope that. So thank you very much again, all. And I wish you have the very productive, fruitful discussion between our community and also successful rest of the week, and then enjoy the dinner. Thank you very much. Thank you.
So, the good news is we only finished half the wine, so the other half is left, and it's all waiting outside for you. So please enjoy, take your time. It was obviously difficult to drag all of you in, but clearly you can linger. We've got the space, and it is a beautiful space and a beautiful evening. So thank you all for coming, and I do hope that when we do this again, we'll have, in response to sort of Jan Arne's question of how many come from the non-core AMR community, we'll have a lot more. I think we're trying to reach out more. I think the cancer world now, understands. We've got folks from the UICC who are now, understanding that this is important for their constituencies. But it is really important for us to make sure that AMR doesn't get into being a vertical kind of a disease space. It would be a big mistake for us to do that. And we really need to, as people invested in this issue, to go out and make friends and bring in other partners to see what access to antibiotics can do for them. So with that plea, thank you to the Lancet team, thank you to my co-authors, thank you to the co-host for the evening, and thank you to all of you. Have a good evening.